everyone. Welcome to the AHI, Adirondack Health Institute, Telemedicine, Telehealth regional presentation. We're very excited to have a number of great people here to talk to you today. My name is Courtney Shaler-Smith. I am the network coordinator for the Rural Health Network. I'm going to do a little bio for Dave Johnson and then call him up to present for about 45 minutes. Then I will do bios on the panelists, short ones I promise. They will do their story and talk for 5 to 8 minutes, and then we'll open the floor up for questions. I did want to cover some housekeeping stuff. If anyone has any issue with being taped, we are taping this for our YouTube channel, so if you don't want to be taped, stay toward the back. The bathrooms are around to the left and over here, and obviously the exit is here, just to be on the safe side. Okay? All right. David Johnson coordinates the North Country Telemedicine Project under the North Country Healthcare Providers in partnership with Fort Drum Regional Health Planning Organization. Dave holds a BA from SUNY Potsdam and has a master's in divinity. He recently became a certified Telehealth Liaison at the National School of Applied Telehealth. Thank you for coming to join us all the way here.
All right. Thank you very much. Good afternoon, everyone. Can you hear me okay? Excellent. So it's a real honor for me to be with you today. Believe it or not, I guess you can believe this, I've had lots of different experiences, and I'm very, very new to the healthcare industry. Just about a year ago, I started with North Country Healthcare Providers in partnership with FDR-HPO, or the Fort Drum Regional Health Planning Organization. So I've learned a lot. I've learned a little bit about your language, lots of acronyms I've had to learn, FDR-HPO, MCHP, AHI, CMS. I could never figure out why that stands for what it is. Then there's DISRUP and FIP and SHIP, and if I say them too fast, I get into trouble. So there's another acronym, Tracy Leonard, who was our network director for a long time, she always likes to mention this acronym. You've heard of PSI, right? You know what PSI stands for? Pounds per square inch, yeah. How about PEPSI? Anyone? That's Pepsi. So, I stole her joke just to get us rolling. So lots of things we want to cover today. I have some things that I prepared, and then there's some things that, I'll just minimize that real quick.
Yeah. Oh, you can hold back up.
There we are. So some things that I prepared as a part of our agenda items, and then there's some things that you actually filled out in your survey to request. So here's what we're after today. First of all, just to level set a little bit, wanted to talk about, okay, how do we define telehealth? Give some basic definitions. What are the barriers that we face? What we're doing in the face of those barriers? And then our project processes, how we go about developing projects for telemedicine, our policies and procedures, and then project funding opportunities. Here's some things just to throw out there as a teaser, other things that we could be talking about today that we won't be, but I'm just planting the seed that maybe you'll invite me back, so there's more to talk about there. Okay, understanding key terms. Let's talk about this. I like to kind of speak all the same language. So the way that I define telehealth is really the overarching umbrella for many different applications, which include clinical applications. Then there's educational, administrative functions as well. So there's lots of different applications for technology, telehealth, right? So clinical, educational, administrative. Telemedicine then would be the clinical application of telehealth, okay? Just so we're all on the same page. And then another key term that you'll want to just be aware of is the idea of hub and spoke. Now there are different models for telemedicine, clinical applications. Hub and spoke is one of the most common applications of telemedicine. So can anybody tell me what hub and spoke refers to? Anyone? Okay, that's why I'm here. I'm here to tell you. So hub is where the specialist is located, right? A hub is where the specialist is providing care. The spoke is where the patient is located. All right? All on the same page. There's a test at the end. So first, to get an idea of the amazing technology that's out there, the picture that you're looking at here is of a really Cadillac version of a telemedicine cart. Okay, so this is a really nice version of it. I did want to mention I did have a background in financial planning and finance, but I can't make any recommendations on stocks anymore. And I'm not receiving any funding from any of the vendors that I might mention today. There's my disclosure, okay? But this card is a really nice tool. What you'll see there is on the right-hand side is the monitor for video conferencing. And on the left-hand side is where the interface for various peripherals that we'll talk about here in a second. You can use these various peripherals to present a patient. So here's some of the peripherals. The first one there is your digital stethoscope. So we can listen in on heart sounds, lung sounds, and I did bring one of these along, just so you get a picture of that. While you can kind of pass that around, take a look. Nice little piece of equipment. The next one is our digital otoscope. Courtney, I'll send this your way. So, just typical Welch-Allyn, looks the same, it's just digital now. So the images that are captured here, the sounds that are captured here can be transported via the internet. And then this one, this is actually one of my favorites. This is a general exam cam. You can use it for lots of different applications. Dermatology is key here. But you can also do ear, nose, and throat with it if you like. This looks like a play school toy to me. It is worth $4,500. So don't drop it. Okay, be very careful.
Hand that to Dylan.
There you go. And then this is a ultrasonic probe. I haven't actually seen this one used yet. So, but you can imagine the applications that are available there. Here's a couple of the tools that we don't currently have in our region, but we're hoping to get. One there's a pulse oximeter, and then the non-mydriatic retinal camera. That's about $20,000, so they're hard to come by. Okay, so that's a look at some of the technology, and then later I'll give you the opportunity to kind of play around with our health buddies. These are remote monitoring units that allow for patients in their homes to report lots of different data. So I use a program, I report in data on my blood pressure and my weight, answer various questions, report it to a care manager who then can see the red, yellow, green indicators to see if this patient needs urgent attention, maybe deserves a phone call. So that's some of the technology. And it can be very expensive and it can be very complicated, but it doesn't have to be. It doesn't have to be all that complicated. It doesn't have to be all that expensive. So the image you see here is of a pretty typical desktop computer with a camera on it. And that can be used for lots of different telemedicine applications. So telepsychiatry is one of the easiest to implement, and in our region, and I think in this region as well, one of the most needed points of care. So it's a huge opportunity. We can do a lot there. Tell a quick story about that. There's a telepsychiatry project that we have up and running, And what they're experiencing is that patients actually seem to appreciate the telemedicine part, the telepsychiatry part, more than the in-person encounters. A couple reasons for that. There is a little bit of a barrier, and that barrier makes it nicer to the patient. The other thing that's interesting about it is there's a less of a, potentially less of a stigma in this case because the patients are being seen in a primary care office. So they go to their primary care provider. They don't have to go to, a psychiatrist located in another facility where there's some stigma perhaps attached to it. So great application. Another thing I'll tell you about that little project, we had a case where there was a young boy who was seeing a psychiatrist at the primary care's office. And he went in, sat down in the primary care office, waiting room, and grabbed his chair, said, "I'm not moving. I'm not going in there." And the staff continued to coax him, try to encourage him to go in to his appointment. But he would not go. Finally, one of the staff people said, "You know that the doctor's on TV, right?" And the little boy jumped up out of his chair and went right into the exam room. So it makes for a nice opportunity there. So if it's so great, why isn't everybody doing it, right? If it's as wonderful as we think it is, why isn't everyone doing it? Well, there are multiple barriers, multiple challenges. The number one challenge has been and continues to be at this point reimbursement. Reimbursement is the big challenge for telemedicine. So lots of things to think about, like who covers telemedicine, Medicare, Medicaid, various private insurance companies, how does it work in your payer mix? And as it has been, you've needed to be really concerned about where a patient is located, where the specialist is located, the type of specialist that you're working with, the type of provider that you're working with, what particular service you're attempting to offer through telemedicine, and then whether the service that you're after is live or synchronous, a live synchronous encounter, or is it a store and forward technology? Store and forward just means I capture some images, I send those images, and the specialist then reviews them when they get to it, when they're after it. So lots of challenges around reimbursement because there's so many rules. And you can imagine a presenting site. You can imagine if you're dealing with a patient and you have to go figure out, well, can I offer this service and see reimbursement? Can I even do that with this patient that I'm working with? So pretty challenging. Now this slide, I don't expect you to really see that. I can provide that to you, so you'll be able to capture this. This is our attempt to make it simple. Okay, you can all laugh now, right? There's a lot to it, and a lot to understand who the payers are, where they're located, and can we get reimbursed. The good news is that here we are in New York State. At the end of last year, the legislature approved the reimbursement or parity bill 7852. So we're very excited. That's why I have fireworks in the background there. Very excited. So we're the 22nd state to offer reimbursement through private insurance companies and Medicaid. So really good news. The bill was passed in December, and the governor had some concerns about that bill, but he passed it with some chapter amendments. Okay, so he's made some modifications to what that bill looks like, and that actually makes it somewhat less exciting. Sorry to say. So first, the law doesn't go into effect until 2016. Well, that makes it a little less exciting because we were hoping for this year. But that's only a few months away when you think about it. The second thing is the chapter amendments placed restrictions on where a patient can be presented from. So the originating site, there's some restrictions on where the originating site, if they can get reimbursed. Okay? I won't go into all the details about that, but Article 31's, that's one of the issues. So, any questions about that piece right there? I'll take other questions later, but I just wanted to make sure I'm being clear about that. Questions? Okay. So, this is who we are. I know people usually start this way, but like you really don't care who I am until now, right? So, North Country Healthcare Providers is a rural health network, and it's a membership organization, so we have these member hospitals. And you can see we kind of cover both here and then back closer to where I'm from, near Watertown, New York. But this is probably more interesting when you think about it. This is our fiber network. And so the fiber network really makes telemedicine possible because when you're pushing lots of audio and video at the same time, it requires a lot of bandwidth. And the fiber network makes that possible. So we're excited about it. All the red lines there that you see kind of is the actual fiber. And it's the combination of two networks. The North Country Telemedicine Project, which is kind of the west side, and then the Action Network on the east side. That's this area. So, and it's, this slide in particular is fairly impressive to people as I talk about it across the state. If you go to Albany and you talk about our network, you go, wow, you cover a big geographical area, and there's a huge opportunity. So we're actually in a position in the North Country, across this region, to be a regional center of excellence for telehealth, which is pretty exciting. Okay, I won't go through every single one of these, but here's a look at some of the current projects that we're doing, and this is, again, even given the barriers around reimbursement. You'll see there, telepsychiatry is one of our key focuses. Working with different partners like St. Joseph's and the community clinic of Jefferson County, we pretty much will work with anybody. We'll work with you if we can get a project up and running. Let me tell you about the jail one in particular, Jefferson County Jail. It's a small project. We have one psychiatrist who provides care to the inmates. Here's why it makes a big difference though. In the past, those inmates had to be transported from the jail to the clinic. When they do that, of course, the prisoners need to be shackled, hands and feet, and they kind of shuffle through and are transported by two, what do they call them, corrections officers, right? So when a corrections officer goes out on one of these visits, he gets overtime to do that. And so there's overtime costs, there's the stigma, the kind of sense that as the patient goes out and sits in a waiting room in the clinic. But then there's also, at the clinic, you look at the issue of, God, they're sitting next to people that maybe they don't want an inmate next to them. Okay? Or the other people located in the building where the community clinic is, they get nervous when they see security guards and inmates. So the Telepsychiatry project there, you can see not only are we able to provide care, but we overcome a number of different kind of value-added pieces that are really helpful there. You'll see the teleneurology project there, that's specific to Parkinson's disease, movement disorders. I got to actually see the test patient visit for that. It was very powerful. One of the things that happened there was this. It was a test patient, but it was a live patient, real patient. He kind of was willing to play to make sure that this was going to actually work. So one of the first things he said to the provider was, yeah, I'm really happy with my current provider, and I have a great relationship with him. But in the course of the exam, in the course of the encounter with this patient, you could see very quickly how strong of a relationship you could develop with a patient, even though it's through video. So much so that at the end of the encounter, there was a really strong bond between these two people. So, remote monitoring, I'll just mention too. We use those with right now 4 different community-based organizations. Public health, one of those. And here's a kind of an interesting one. Now this is hard to say. And I invented it, right? So telemedication reconciliation. Go ahead and say that a few times fast. The idea there is we have a pharmacist who says, listen, I will do this. I will work with patients, but I can't get them to come see me sometimes. So we have health aides who go into the homes and they spread out the medications, point their iPad at the medications, and the pharmacist looks at them, talks with the patient using an iPad. Kind of cool. I throw this up here too, just so that you can see that there's also the administrative and educational opportunities through telehealth. We do run, and I'll mention it, and it's on your sheet there, the Telehealth Learning Collaborative. That's something we started basically because we had questions with the Department of Health and OMH. And we said, let's get on the phone. So we got on the phone and we started talking, and then other people wanted to be in on the conversation. So we said, well, let's do a video conference. So we meet the third Monday of every month. And if you'd like to be a part of that, as you build your own programs, as you're building your projects, just contact me, I'll send you the invite, okay? These are projects in development. There's a lot of them. We're actually currently working now with 64 different organizations. When I started a year ago, we basically had 2. So it's really starting to grow, really starting to develop, and I feel like my sense is that we're just on the verge. When reimbursement, that barrier goes away, I think telemedicine, telehealth will explode. So as much as we can get ready, as much as we can move the ball down the field before January 1, 2016, let's get to it, right? So lots of different projects there. I guess I don't have to mention the other. Telehospitalists, I'll just mention that one. So because of the peripherals that we sent around the room, and I hope nobody walked out with those, right? Because I gotta take them back. Those peripherals, that allows, in the project that we're working on, it allows something to take place. Something that happens in our region, I don't know if this happens here, but we have Samaritan receiving patients from other hospitals. And sometimes the communication between those hospitals hasn't been all that great. It hasn't been strong enough. And what happens is the patients get sent to the ER and then admitted on a floor. So the hospital said, listen, we could probably avoid an ER visit if we could just see the patient. Can we just see the patient and kind of work with that patient and see if we might avoid an ER visit? And so that's what we're working on now. GME training, that's another thing, that's an easy one, right? So we got the camera going here now. Imagine if you could live video stream that, all your GME stuff, broadcast it out to other sites. It's a good opportunity. Okay, this you'll also receive from me. It's our process chart. So this is how we kind of walk through developing a telemedicine project. So step 1 is to define the needed service. What is it that you're going to do? What is the service that you're going to provide through telemedicine? So you need to think that telemedicine is not a separate service. It's a different way to deliver the same service. So if it's psychiatry, now it's just telepsychiatry. If it's neurology, now it's teleneurology. It's a different way to deliver the same service. Step 2, find the specialist. Now this, I can tell you, in my experience, has been one of the most challenging. This has been pretty difficult at times. To find a specialist who is willing to kind of examine the use of telemedicine, and who has the capacity to do it. Like, do they have time to actually invest here? Third step, to connect the hub and spoke. So wherever this service is needed, then how do I got to get these players together, get the specialist and the spoke site together. Once we do that, I select the start date. So I do that kind of from a strategic planning point of view to say, I want to put that date out there, make sure I've got a date solid so that everything else that we're going to do kind of is implemented toward that date. I can tell you that often our dates get pushed back. So we select a program date, we got everything working, but it takes time and things get off track sometimes. So sometimes we've had to push that big date back, but having a date means that we're actually all together working on the same goal. Equipment acquisition and preparation. This one, in our region, we have 6 area hospitals that received equipment from FDR HPO through grant funding. So here's how it worked, and you guys all know this, right? You get the grant, they tell you got to buy the equipment. So you buy the equipment before you have a program, and you go deploy that equipment, but we don't have a program to actually do anything with it. So all the equipment got shipped out, and they sat there. Right? But six of our hospitals, and soon to be 7, will have kind of that really nice Cadillac version that you saw of those telemedicine cards. And then we got a bunch of just simple HP all-in-ones to do the same thing. So we have actually a decent amount of equipment to get out there. But for some sites, you're going to need to purchase equipment. You're going to have to dedicate resources to it. And so you got to plan on that. Completing appropriate paperwork, the next step. This one's challenging as well, because what we're talking about here is credentialing. That's a big one. Credentialing, as you know, can take a long time, at least longer than I would like it to go. I'd like it to go much faster. And then there's issues around billing and all of our policies and procedures, which can come later. No, that's the next one. So refining the policies and procedures. This one, I'll talk more about the different pieces that go into policies and procedures, at least from our point of view. But that needs to be kind of hashed out between the hub and the spoke. Drop off the equipment, set your room up wherever you're going to do this, and I can tell you the room size does not need to be huge, depending on whatever you're working on. You can do this in a closet. You really can, right? I hear some amens there. Schedule the patients. So this one, I usually like to recommend that people do a test patient. So it's an actual patient, it's a live patient, but somebody who's willing to support and won't be too upset if it doesn't work. If there's a technological glitch, or there's some kind of administrative glitch. If something doesn't work right. So if you're thinking about telepsychiatry as a project, you gotta be careful about that. But I'd like to have a test patient, so you actually go through the whole process with a real patient. Test it out, begin the process, and then kind of the final one is the evaluation. So you need to have a part of your process to always be, we're evaluating what's taking place, we're seeing if we can do it better all the time. Okay, this won't mean anything to you, but I wanted you to see, this is kind of a dashboard. It's just got a few of the 64 different sites that we're working on. As I kind of walk through the process with different people, I just kind of determine where they are in the process and keep track of that. This I largely do for reporting, right? So if you're grant people, reporting is good. All right, our policies and procedures. I'm just going to highlight some of the things that you'll want to have as a part of your policies